Okay, next discussion concerns the small bowel. The first disorder is duodenal atresia. Again, when you have something that's atretic, it ends in a blind loop. And so basically the idea here is that the duodenum ends in a blind loop. The reason why we get this is congenital, and it's failure of the small bowel to actually canalize. Highly associated with Down syndrome. That's a high yield association for examination purposes. Now the clinical features are all based on the fact that you're going to have this blind loop. So for example, if this is the esophagus, and then you've got the stomach coming off, and then eventually you have the duodenum is ending in a blind loop. So one problem that's going to occur is polyhydramnios. Now polyhydramnios means too much amniotic fluid. Remember that the amniotic fluid, the major component, is generated from the urine of the baby, so that the urine of the baby is the major component of the amniotic fluid, and at the same time, the way by which we resorb some of that amniotic fluid is by swallowing it and digesting it, so that the baby is swallowing and digesting amniotic fluid, and that helps to decrease the volume of amniotic fluid. If we don't have that physiologic swallowing and digesting, we're going to get too much amniotic fluid, or polyhydramnios. And of course, in this particular case, the babies can bring in a little bit of that amniotic fluid, but they can't pass it through the rest of the gut. So this would be one problem that could arise in these babies. Another problem is that they get bilious vomiting, and the idea here is that as you get building up of the food within this tract, of course it ends in a blind loop, and of course the bile is coming in from the duodenum, and so this is going to end up being regurgitated out, and that's going to result in vomiting, and it'll be bilious because it's got bile coming in at the level of the duodenum. So that's an important clinical feature. And the third important clinical feature is that you're going to get distension of the stomach, and you're also going to get distension of the duodenum. And in between here is the pyloric sphincter, which is going to remain tight. And so that's going to produce two separate areas of distension, and that is called the double bubble sign. It's best visualized by imaging. So here you've got the stomach, for example. There's a tightening here where you have the pyloric sphincter, and then here you've got the duodenum. So two bubbles, bubble number 1 and then bubble number 2. Double bubble sign, very high yield for examination purposes. Meckel's diverticulum, remember that a diverticulum is an outpouching of a wall. That's the first point. And in this particular case, you get outpouching of all of the layers of the bowel wall. So that's called a true diverticulum. Remember that you can also have false diverticulums. For example, the one diverticulum that we've covered in this chapter so far was a Zenker's diverticulum, in which you had outpouching of the mucosa through the muscle wall or through the muscle layer. And so that was a false diverticulum. This is a true diverticulum, and it's one of the few true diverticulums that we're going to study. Now this arises embryologically due to a failure of the vitelline duct to involute. Let's talk about the vitelline duct for a moment. Remember that in early embryonic development, the midgut actually receives its nutrients from the yolk sac. So early in life, when we're developing the baby or the fetus, the midgut is actually going to receive its nutrients from the yolk sac, and the way by which it receives those nutrients is via the vitelline duct. So we could say that the vitelline duct is vital for receiving nutrients during early development. This duct normally forms in about the 4th week. It then involutes by about the 7th week of gestation, and if you have persistence of the duct, that results in something called a Meckel's diverticulum. So it's really persistence of the vitelline duct. It's interesting, you can have a couple problems here. One problem is that you can have the fact that the duct does not involute at all, and that would result in the passing of meconium via the umbilicus at birth. So if they gave you an examination question in which the patient is passing meconium via the umbilicus, that means that there was failure of the vitelline duct to resolve completely, meaning that there was no resorption or no involution of that duct at all. But it's also possible that you can get a slight closing of that duct, but it fails to involute completely, and that would result in something called a Meckel's diverticulum. One of the interesting things that may be seen, especially on examination when you do a clinical exam on these patients, is you can kind of feel the umbilical area, and it feels like there's stool. There feels like there's something firm but soft, or something solid but soft within the umbilical area, and that's because there's stool caught up in the Meckel's diverticulum. So that's an important, interesting finding as well. Now, this is what the Meckel's diverticulum looks like. This is basically the diverticulum here. It's an outpouching coming off the intestine, and the intestine, of course, would be running this way. Now, there's some rules of twos that are highly associated with the Meckel's, and you do need to be familiar with them. They help you to remember some of the important clinical and epidemiologic features. Number one, it's seen in 2% of the population. It's the most common congenital anomaly of the GI tract. It's usually 2 inches long, and it's usually located in the small bowel about 2 feet from the ileocecal valve. And again, by here, you can imagine that this would be 2 inches long. So those are the rules of twos. There's a few more. First of all, this usually occurs. Usually it's asymptomatic, but if it does present, it can present within the first 2 years of life. And the way by which it can present includes bleeding, volvulus, and a volvulus is where you get a twisting of the bowel on its mesentery. It can present with intussusception, and intussusception is when you get telescoping of the bowel, or it can present with obstruction. This bleeding is particularly important, and that's because you need to know that within a Meckel's diverticulum, you can also have heterotopic gastric mucosa. Now, that gastric mucosa would produce acid, and then you'd get acidic damage to the Meckel's diverticulum, which would then present as bleeding. All right, next disorder is a volvulus. This is when you get twisting of the bowel along its mesentery. Now, remember that if you've got bowel, the blood supply is coming in through the mesentery. So if you twist the bowel along its mesentery, you're going to create 2 problems. Number 1, you're going to obstruct the bowel, and number 2, you're going to disrupt the blood supply. And of course, a disruption of blood supply will result in infarction. Now, the most common locations are those locations where you have a ton of mesentery, so that there's some redundancy that allows for this twisting. So in the elderly, the classic location is the sigmoid colon. And in a young adult, the classic location is the cecum. Here's what a volvulus looks like. Basically, this area here has been twisted, and this area is normal, and this area is normal as well. And so when this twisted, there was infarction of that area, and you can clearly see that this is a hemorrhagic infarction of the bowel. Now, intussusception refers to telescoping of a proximal segment of bowel into the distal segment. Now, here's basically the idea. Let's pretend that this is the bowel, and the flow is moving this way. The idea is that you kind of drag in the bowel along the direction of flow, along the direction of peristalsis. So that's called intussusception, the telescoping of a proximal segment into a distal segment. Now, what's important to note about intussusception is that obviously when you drag in the bowel, you're going to be dragging in the blood supply as well. And so that dragging in of the blood supply is going to result in infarction. And these patients classically present with obstruction or with infarction, and that infarction can often present itself with something called current jelly stools. Now, it's important to note that whenever you have intussusception, usually it's associated with a leading edge. Now, remember I said that basically it's in the direction of peristalsis. So there's got to be something that the peristalsis can kind of hook on and grab the bowel and drag it forward. And so you want to ask yourself the question when you have an intussusception is, what was the underlying cause that allowed the bowel to get dragged forward? And in children, the most common cause is lymphoid hyperplasia. So remember that there are a ton of Peyer's patches within the intestine, and those Peyer's patches are particularly prevalent within the terminal ileum. So the idea is the patient gets some sort of, or the child gets some sort of viral infection, they get massive lymphoid hyperplasia, and the terminal ileum gets dragged into the cecum because of the thickness of its wall. In adults, you'd classically think about tumor as being the leading edge that allows for an intussusception to occur. Small bowel infarction, we should know that the small bowel is very susceptible to ischemic injury. Remember that the small bowel needs a lot of ATP because it's doing a ton of digestion. It does a lot of the absorption and a lot of the digestion necessary to be able to bring nutrients into the body. And so it's going to be highly susceptible to ischemic injury. Now, when you get ischemia of the small bowel, there's a couple possibilities of what could occur. One possibility is that you can get a transmural infarction, and this is going to occur. Let's pretend that this is the bowel and this is the blood supply coming in, and this is the blood supply coming out. So you've got an artery and you've got a vein. Now, transmural infarction is going to occur when you get thrombosis or embolism of the artery, and it's got to be the superior mesenteric artery, or if you get thrombosis of the vein. It's kind of that same paradigm that we keep talking about. Now let's ask a couple questions. How would we get embolism of the artery? Well, one way by which we could get embolism would be if the patient has atrial fib. Remember, if the patient has atrial fibrillation, then basically the idea would be that they can develop a thrombus because of the lack of motility of the atrium, and that thrombus could break off and then embolize, and that would be called a thromboembolus, and that could lodge itself in the SMA and then create an infarction. The other possibility would be that the patient, for example, has a vasculitis, and so if the patient gets a vasculitis, that can increase the risk for thrombosis and subsequent infarction. For example, one classic example would be polyarteritis nodosa, in which the patients actually had melena and abdominal pain. And if you go back and review polyarteritis nodosa, you'll see that one of the features was abdominal complaints. And then the third way would be to get thrombosis of the mesenteric vein. And how would you get thrombosis of the mesenteric vein? Well, one classic mechanism would be something called polycythemia vera, where you have a red blood cell disorder where you're producing too many red blood cells, which makes the blood thick and increases the risk for thrombosis. Another classic example would be if the patient has a lupus anticoagulant, that would increase the risk for thrombosis as well. So in these particular cases, when you're going to block the blood supply, that's going to result in a transmural infarction so that the entire wall gets infarcted. Now the other possibility is that you can get a mucosal infarction. And the way that by which that would occur is that if you've got this blood supply going to the wall and you've got a mucosa and a submucosa, etc., and here's the blood supply, imagine that you don't cut the blood supply completely, but that you decrease it slightly. If you decrease it slightly, then the mucosa, which is furthest away from the blood supply, would actually become ischemic, and you'd get infarction only of the mucosa. And that occurs when you have marked hypotension. So when there's hypotension, then you can get mucosal infarction instead of a complete transmural infarction. The clinical features, of course, will be abdominal pain with bloody diarrhea. These are the key features of infarction. And there will also be decreased bowel sounds as the bowel becomes less active. The next disorder we want to discuss is lactose intolerance. This is due to a decreased function of the lactase enzyme that's present in the brush border of the enterocytes. Before we can understand this, we need to do a little review of physiology. Let's remind ourselves that one of the nutrients that we want to take from the gut and bring into the blood is going to be sugar or carbohydrates. Remember that carbohydrates are broken down into oligosaccharides by the amylases in the salivary gland and the pancreas, and also into disaccharides, such as lactose and sucrose. Now, eventually, you can only absorb monosaccharides, and so you've got to break down all of those oligosaccharides, and you've got to break down the lactose and the sucrose as well into monosaccharides. And remember from biochemistry that there are 3 monosaccharides that are going to be absorbed: glucose, galactose, and fructose. Now, in order to break down lactose, we have an enzyme present on the brush border of our enterocytes, which line the small bowel, and that is called lactase. And you need this lactase enzyme to break down lactose. If there is a decreased function of the lactase enzyme, then what's going to happen is that the lactose will remain within the lumen of the small bowel, and lactose is osmotically active. It'll draw water towards it, and that'll create a diarrhea. So how will these patients present? They present with abdominal distension and diarrhea when they consume milk products, and that's because milk products contain a ton of lactose. Now, when you get deficiency, it can be congenital or acquired. The congenital deficiency is rare. It would basically be a child who was born without the enzyme. That's super rare. You can also get acquired deficiency, and acquired deficiency occurs in 2 ways. One way by which patients get acquired deficiency is simply as they age, they just become intolerant. And this is classically would occur, for example, in a child. So maybe like a 10-year-old, 15-year-old child who was normal up to that age, and then all of a sudden becomes lactose intolerant. And of course, they would be lactose intolerant for the rest of their life. Another acquired way to get lactose intolerance would be after any GI infection. When you get a GI tract infection, for example, a viral infection of the small bowel, that can destroy the enzyme, and therefore the patients can become lactose intolerant. But of course, that would be temporary until the small bowel would actually heal. The next disorder is celiac disease. This is immune-mediated damage of the small bowel villi. So that's the key thing. You're going to knock out the small bowel villi, and it's due to gluten exposure. Basically, this is a hypersensitivity. There is an antigen out in the environment that when it hits the bowel results in destruction of the small bowel villi. It is associated with HLA-DQ2 and HLA-DQ8. Now, the key component that is going to result in this hypersensitivity is something called gluten. And gluten is present in wheaten grains and is in very many foods that we consume. The most pathologic component of gluten, you have to know for examination purposes, is gliadin. And you also need to know that gliadin gets deamidated. Now, when this occurs, it occurs via tissue transglutaminase. Now, this changed or altered gliadin is then grabbed by the antigen-presenting cells and then presented via MHC class II to the helper T cells. And it's the helper T cells that mediate the tissue damage. So it's the T cells that are creating the problem here. Now clinically this can have a very broad presentation, but the classic finding in children would be abdominal distension, diarrhea, and failure to thrive, and in adults it would be chronic diarrhea and bloating. So this is and these are the ways by which we would classically see a presentation of this particular disorder. Now one associated finding is something called dermatitis herpetiformis, and the idea here is that if we draw a picture of skin, this is the epidermis up here. All right, so this is the epidermis, and underneath it is the dermis, and remember that we have dermal papillae here. Now recall that the blood supply of the skin is all in the dermis. There are no blood vessels in the epidermis. So as blood vessels come up here, one of the things that can happen in this disorder is you can get deposition of IgA at the tips of these dermal papillae. Now the deposition of IgA at the tips of the dermal papillae will result in destruction of the connection between the epidermis and the dermis at that point, so that what you'll get is a little blister or vesicle right here at the tip of the dermal papillae. And then you'll get another tiny little vesicle here, and then another tiny vesicle at the dermal papillae here. Now these are little tiny vesicles, so they look like herpes, and so that's why it's called herpetiformis. You get very similar herpes looking like blisters. And so what's important to note is that it's due to IgA deposition at the tips of the dermal papillae, and that it resolves with a gluten-free diet. Now the laboratory findings are that you get IgA antibodies against a few things. Number one, endomysium. Endomysium is the connective tissue that ensheaths each individual muscle fiber. In this particular disorder, there is no problem with the endomysium, but it so happens that they develop antibodies against endomysium, and so that's one thing we can test for. They also can get IgA against tissue transglutaminase or IgA against gliadin. So these are the classic laboratory findings. Now what's interesting about patients with celiac disease is that a subset of these patients can be IgA deficient. Remember that when we talked about IgA deficiency in your immune lecture, I mentioned at that point that there's an increased incidence of IgA deficiency in patients with celiac disease. And so if they're IgA deficient, then you're not going to be able to find the IgA antibodies. And so it's also important to test for IgG antibodies, because those will be useful for diagnosis in patients that have an IgA deficiency. Obviously, if you have an IgA deficiency, you won't have IgA against these particular antigens, and so in those patients we want to look for IgG antibodies against, for example, tissue transglutaminase is just one example. Now the way by which we make the diagnosis is also to do a duodenal biopsy. The biopsy will show flattening of the villi and hyperplasia of the crypts. Let's go back and remind ourselves that this is the small bowel surface. You've got these villi that go up, and you've got these tiny crypts that come down. So villi that go up, and then tiny crypts that come down. Now what happens in this disorder is you get flattening of these villi, so you're going to lose these villi. You're going to get hyperplasia of these crypts, so the crypts are going to become deeper, and then you're going to see lymphocytes within the epithelium, and so you get an increased number of intraepithelial lymphocytes. And here's what it looks like. You've got flattening, here's the surface, there are no villi, so you've got flattening of the villi, but you've got hyperplasia of these crypts, and then you've got all these lymphocytes present. In particular, you would see them within the epithelium up here. Now this is the normal histology, just to remind you that you normally should have these nice tall villi, and then these crypts should be very minimal. All right, and so again we're losing all of these villi in celiac disease. Now one more important point that I make here in the notes, and that is the distribution, which is super high yield. The damage is mostly in the duodenum, and the jejunum and ileum are less involved. I can't repeat that enough. Remember that the damage is mostly in the duodenum, and the jejunum and ileum are less involved. All right, of course, as I've already mentioned, the symptoms resolve if you put the patient on a gluten-free diet. Now let's say that on an examination in particular, the patient's on a gluten-free diet for many years, and they swear up and down that they've been maintaining that diet. Now all of a sudden they start getting disease, again, refractory disease, despite the fact that they claim good dietary control, and they've had good dietary control for several years. Then you need to think about two particular complications that could be leading to this refractory disease. The first would be that the patient could have developed small bowel carcinoma. So there's an increased risk for development of small bowel carcinoma in patients with celiac disease, especially with long-standing celiac disease. And then second, it's a possibility that the patient developed a lymphoma. But what's interesting here is that these patients can develop a T-cell lymphoma. And that's kind of rare because we haven't talked about many T-cell lymphomas. We've talked about a lot of B-cell lymphomas throughout this course. And so it's important to know that these patients can develop a T-cell lymphoma. And it's all, that T-cell lymphoma is also called EATL, E-A-T-L. And that stands for enteropathy-associated T-cell lymphoma. But anyway, I think the most important thing for you to note is that if there's refractory disease, think about cancer, think about lymphoma, and in particular a T-cell lymphoma. Now, tropical sprue is another disorder that's very similar in that you get damage to the small bowel villi, and when you get damage to the small bowel villi, in this particular case, it's due to an unknown organism. Of course, it results in malabsorption. Whenever you knock out the villi, you're going to get malabsorption and diarrhea. Now, this is very similar to celiac disease with a couple exceptions. Exception number one, it occurs in tropical regions like the Caribbean, and of course, that's because it's due to some infectious agent, and that's where the infectious agent tends to be located. Number two, it arises after infectious diarrhea. So you clearly have an infection, and then the patient develops this tropical sprue. And it also responds to antibiotics, indicating that it's being driven by this infectious agent. But here's the super high yield point that I want to make, and that is that in tropical sprue, the damage is more in the jejunum and the ileum, whereas in celiac disease, the damage was more in the duodenum. But the duodenum is less commonly involved in tropical sprue. So the predominant disease is in the jejunum and the ileum. Now, because the disease is predominantly in the jejunum and the ileum, you can also get nutritional deficiencies based on what is occurring in the jejunum and the ileum. So remember that in the jejunum, that is the key place where we absorb folic acid. So we can get folic acid deficiency. And also, the ileum is the key place where we absorb vitamin B12. So we can theoretically develop a vitamin B12 deficiency. Okay, next disorder is called Whipple's disease. This is a systemic disease in which you get macrophages loaded with T. Whippelli organisms. Okay, what's the idea here? The patient gets a T. Whippelli infection. The macrophages begin to eat away at the T. Whippelli, trying to kill them, but instead of killing them, they can only partially destroy them. And because they can only partially destroy them, the organism remains within the macrophage lysosomes. And so that's an important consideration because in this disorder you're going to get tons of macrophages loaded with the bugs. Now the classic site of involvement is the lamina propria of the small bowel. And that's very important because that's then going to lead to the classic symptoms of this disorder, which is fat malabsorption and steatorrhea. But before we can understand that, we need to take a little step back. So let's remind ourselves that when you think about the small bowel, you've got these villi, correct? And the villi have these enterocytes. All right, and the enterocytes are sitting on a lamina propria. The connective tissue of the villus is called a lamina propria. So that's the first point that I want to make. Now I'm going to go back and draw that with that background in mind. So you've got these enterocytes and then you've got the lamina propria. Now let's talk a little bit about fat digestion. So lipids are obviously broken down by lipases from the salivary gland and lipases from the pancreas, and then they're emulsified into smaller droplets in the stomach and the small bowel. And bile, of course, helps in that emulsification process. The end result is the production of a micelle that easily diffuses across the cellular membrane, which then brings in the fatty acids into the enterocyte. And once you have fatty acid within the enterocyte, then the next thing that's going to happen is you're going to repackage those fatty acids into chylomicrons. Now, chylomicrons are relatively big molecules, and they're going to come out into the lamina propria. They can't go into the blood. And when they go into the lamina propria, they're going to be resorbed in these small little lymphatic spaces called lacteals. So the chylomicrons are going to be brought in to these lacteals. And then, of course, they go into the lacteals, into the lymphatics, and the lymphatics eventually drain via the thoracic duct into the blood. So that's the way by which the chylomicrons are brought into the blood. They can't go directly into the blood. They have to go into the lymphatics, and then eventually they land in the blood because of their size. Now what's going to happen in this particular disorder, which is Whipple's disease, is that you're going to get a ton of macrophages. So let's just make them with squares, okay? You get a ton of macrophages present within this lamina propria. Now all those macrophages are going to pile up, and they're going to eventually compress these thin-walled lacteals. So if you compress these thin-walled lacteals, you can't bring the chylomicrons in anymore, and if you can't bring in the chylomicrons, the patients are going to get a fat malabsorption. And that's exactly the mechanism by which they get fat malabsorption and steatorrhea. All right, here's what it looks like. This is the small bowel villus here. All right, and these are the enterocytes here, and you can see that there's all these foamy macrophages within the lamina propria, as I've just sort of outlined. Again, foamy macrophages in the lamina propria. Now I could prove that these are macrophages loaded with the organisms by doing a special stain called a PAS stain, which would show me the little organisms, and this dark pink material within the macrophages indicates that I'm actually dealing with Whipple's disease, because I can clearly see the little fragments of the organisms. Now remember that this is a systemic disease, so that the most common site is the lamina propria of the small bowel, but it can also involve the joints giving you arthritis, in particular the synovium, the cardiac valves, the lymph nodes, and the CNS. So that's something to bear in the back of your mind. The next disorder that we're going to talk about is A-beta lipoproteinemia. A means without, and this is without your beta lipoproteins. Now the idea here is that you get an autosomal recessive deficiency of apolipoprotein B48 and B100. Now what's B48 important for? You need B48 to make the chylomicron. So if you can't make the chylomicron, you can't absorb fat, and they're going to get a malabsorption. At the same time, you need B100 to be able to produce your VLDL and your LDL, and so therefore these patients are going to have absent plasma VLDL and LDL. All right, moving along, we're going to talk about carcinoid tumor. Carcinoid tumor is a malignant proliferation of neuroendocrine cells. It's a low-grade malignancy. Now, let's remind ourselves that when you think about tumors of neuroendocrine cells, you can kind of have a spectrum. The worst tumor, and the highest grade, and the worst tumor of a neuroendocrine cell is called small cell carcinoma, and that occurred in the lung, and we've already talked about it. But remember that sort of the lowest form of malignancy of a neuroendocrine cell is called a carcinoid tumor. Now, a carcinoid tumor, it's important to note that those tumors are neuroendocrine, and so they're going to be filled with neuroendocrine granules, and very high yield that shows up on exams often is the fact that these tumor cells will be positive for an immunohistochemical stain called chromogranin. This is very high yield. It likes to show up on exams. So neuroendocrine tumors, in particular the carcinoid tumor, but this would also be true of a small cell carcinoma of the lung, would be positive for chromogranin. Now, carcinoid tumors can occur anywhere along the gut, but the small bowel is the most common site. The way I remember that is to remind myself that every site has cancer. For example, in esophagus, we talked about esophageal cancer. In the stomach, we talked about stomach cancer. When we do the colon, we'll talk about colon cancer. But there really is no common small bowel cancer. Remember that I told you earlier in our discussion that small bowel carcinoma is very rare. And so the way I remember this is that we've got to give the small bowel something, and so we'll give it the carcinoid tumor. So it's sort of just, I don't know, a funny way to remember something that you do need to know. Now these normally grow as submucosal polyp-like nodules, and this is what it looks like. You get these little raised protrusions that are actually submucosal but are creating these little polyps. Now, they often secrete serotonin, and this is very important. So when you have a carcinoid tumor, what's going to happen is, let's pretend that this is the tumor. The tumor is going to dump into the portal vein, and when it dumps into the portal vein, that is going to feed to the liver. And so when it feeds to the liver, then the liver is going to process that serotonin, right? Because, let's start over. The tumor secretes serotonin, dumps it into the portal vein. The portal vein will then send it to the liver. In the liver, it will be processed by an enzyme called monoamine oxidase, MAO. Monoamine oxidase will break down the serotonin into 5-HIAA, which is a metabolite of serotonin, and that will then be excreted in the urine. Now, this is very important because when these tumors secrete serotonin, the only thing you're going to have at this point is an increase in 5-HIAA. There will not be carcinoid syndrome. Carcinoid syndrome requires that the serotonin go into the systemic circuit. However, in this particular case, all of the serotonin has been destroyed by the liver. Now let's pretend that this carcinoid tumor metastasizes so that now the carcinoid tumor itself spreads to the liver. So here's the carcinoid tumor. It's now metastatic into the liver. Well, once it's metastatic into the liver, now the carcinoid tumor can dump its serotonin into the hepatic vein. And when it dumps the serotonin into the hepatic vein, it's important to note that the hepatic vein has tiny connections with the systemic circuit, so that now this serotonin can actually get into the systemic circuit and hit places such as the lung and the skin and create the classic picture of carcinoid syndrome, which again is defined as bronchospasm, diarrhea, and flushing of the skin. All right, so it's important to note a general principle that only when you have metastasis to the liver will you actually get the carcinoid syndrome. I can't emphasize that enough. Now, at the same time, because you've got metastasis to the liver and you're dumping into the hepatic vein will eventually feed into the right heart via the vena cava. And when you get serotonin hitting the right heart, that's going to create fibrosis of the heart valves, and that's called carcinoid heart disease. So again, I'd like to highlight one central principle, and that is you don't get carcinoid syndrome and you don't get carcinoid heart disease until the tumor actually metastasizes to the liver. Carcinoid syndrome, of course, is bronchospasm, diarrhea, and flushing of the skin. These symptoms can be triggered by drinking of alcohol or emotional stress. Both alcohol and emotional stress can actually cause release of the hormone, of the serotonin from the tumor. At the same time, the patients can get carcinoid heart disease when there is metastasis of the carcinoid tumor to the liver, and that's going to result in a right-sided valvular fibrosis. It's important to note that the notion here is that you're going to get deposition of collagen within the valves. That deposition of collagen within the valves can lead to tricuspid regurgitation and pulmonary valve stenosis. So those are the two key complications. Now let me just make one point here very clear, because it's also high yield for board examinations, and that is you don't get left-sided valvular disease. And the reason you don't get left-sided valvular disease is because when the serotonin goes into the right heart, it'll then get pumped into the lung, and the lung also has monoamine oxidase, very important, very high yield. The lung also has monoamine oxidase, and therefore patients won't get left-sided valvular fibrosis because the serotonin will have been converted to 5-HIAA before it gets to the left side of the heart. All right, so you won't get left-sided valvular fibrosis. And that closes off our discussion on small bowel.